Welcome to the Deep Dive, where we really try to unpack the core knowledge on, well, crucial topics. We aim to give you the insights you need, but without all the overload. Today, we're tackling something fundamental for all you future nurses out there: fluid and electrolyte balance in infants and children. It's kind of amazing how fast things can change in these little ones.
Absolutely. It's so true. When you're talking about managing fluids, well, infants and children just aren't small adults, are they? Their bodies, their physiology,
Mm.
it presents these unique vulnerabilities. Understanding those differences is, frankly, essential for safe care.
Okay.
So our mission today really is to break down the key concepts. We're looking at fluid and electrolyte imbalances in kids, using Wong's Nursing Care of Infants and Children as our guide. It's a great resource.
Yeah, classic.
We'll focus on why they're more at risk, how you can spot the different imbalances, signs, symptoms, diagnostic clues, and the essential nursing stuff you'll actually be doing.
All right, this is fascinating stuff. It really is incredible how different their little bodies handle fluids.
Mm.
So let's start right there. Why are they so much more vulnerable compared to, say, older kids or adults?
Okay, well, there are several key physiological differences that really contribute. First off, infants. They're born with a much higher percentage of total body water. Think like 75 to 80% of their weight.
Wow, 75, 80%?
Yeah, compared to maybe 65% in older kids and adults. But what's really important is where that water is. Infants have a bigger proportion of it in the extracellular fluid, the ECF. That's the fluid, circulating outside the cells.
Okay.
And that compartment is just, well, more easily lost from the body than the fluid inside the cells. So boom, they're much more susceptible to rapid fluid loss, rapid dehydration.
Okay, so more water overall, but a bigger chunk is in that more losable space. Got it. What else is going on?
Another really critical piece is their kidney function. It's just immature. In those first few months, an infant's kidneys are still developing. They can't concentrate urine as well. They can't regulate electrolytes as efficiently. So basically, they can't adjust to changes in fluid intake or losses nearly as effectively as older kids or adults can.
Makes sense.
And finally, children just have a higher metabolic rate relative to their size.
Ah, okay.
And this higher metabolism means more insensible fluid losses, breathing through the skin, especially with a fever. All that adds to their daily fluid needs.
So you've got higher potential for loss and a less efficient system for managing it all. That definitely paints a picture. Now, when we think about calculating how much fluid a child needs daily, there's a standard formula, isn't there?
Exactly. And just understanding those compartments, total body water, extracellular, intracellular, helps us see how things shift as kids get older. But yes, for estimating daily maintenance fluids, we use a weight-based calculation. It's pretty standard.
Okay.
For a child up to 10 kilos, you figure 100 milliliters per kilogram per day. Then for every kilo between 11 and 20 kilos, you add 50 mils per kilo.
Right. And then for any weight over 20 kilos, you add 20 mils per kilo for each extra kilogram.
Okay, let's make that concrete. Say you have an 18-kilogram child. How would that work out?
Okay, 18 kilos. So first 10 kilos, that's 10 times 100 milligram kilogram, which is 1,000 milliwatt.
1,000 milliwatt.
Then you've got the next 8 kilos, right? From 11 up to 18. So that's 8 kilogram times 50 milligram, which is 400 milliwatt.
400 mil, okay.
So you add them up. 4,000 plus 400 gives you 1,400 millivolts per day. That's your estimated daily maintenance fluid requirement.
1,400 mils, perfect.
It gives you a good baseline, but you always have to remember individual needs can definitely vary based on their condition.
Of course, yeah. That calculation really helps nail it down, though. Now, what kinds of things, what situations commonly throw this fluid and electrolyte balance off in kids?
Well, we can kind of group them into things that increase fluid needs and things that decrease them.
Okay.
On the increase side, fever is a big one. It just cranks up the metabolic rate, so you lose more fluid. Vomiting and diarrhea obviously cause direct losses of both fluid and electrolytes, critical losses there.
Yeah. Burns are another major one, disrupts the skin barrier, massive evaporative losses. Shock states cause fluid shifts, increasing the need for volume. Tachypnea, just breathing fast, increases those insensible losses from the lungs. Even things like phototherapy for jaundice can increase skin losses.
So it's either losing more fluid than normal or the body just needs more under stress. What about situations where a child might actually need less fluid?
Right. In those cases, the body's usually holding onto fluid inappropriately. Think congestive heart failure. The heart's not pumping well, fluid backs up. Renal failure, obviously, the kidneys aren't excreting fluid properly. SIADH syndrome of inappropriate antidiuretic hormone that makes the body retain way too much water. pressure. And sometimes increased intracranial pressure, ICP, can mess with fluid regulation too.
Okay, that gives us a really good map of the factors that can, tip the scales. Let's zoom in on dehydration now, because that's just so common in PIS. I know there are different types. How do we tell them apart?
Yeah, the three main types are isotonic, hypotonic, and hypertonic. The real difference is the balance between water and sodium loss, which, directly impacts the serum sodium level.
Okay.
Isotonic is the most common. You lose water and sodium equally, so the serum sodium stays pretty much normal, like 135, 145 milli-QL, classic causes. Vomiting, diarrhea.
Gotcha.
Hypotonic means you lose proportionally more sodium than water, so the sodium level drops below, say, 130. This can happen with really bad or long-lasting vomiting or diarrhea, especially if someone's only replacing losses with plain water, or in conditions like cystic fibrosis, where they lose a lot of salt.
Okay, more salt loss.
Then hypertonic is the opposite. You lose more water than sodium. So the serum sodium climbs above 150. This can happen if fluid intake is just not enough, especially with fever or diarrhea, or in conditions like diabetes insipidus, where the body just loses tons of water.
That difference based on sodium levels is really key, isn't it?
Yeah.
Now, okay, regardless of the type, what are those main clinical signs, the symptoms that should make a nurse think, maybe dehydration? What are you looking for?
Spotting those signs early is just crucial. Key things you'll see: dry mucous membranes, like sticky mouth. Reduced skin turgor. You pinch the skin, maybe on the abdomen, and it stays tented up instead of snapping back. In infants, a sunken fontanelle, that soft spot on the head. Tachycardia, the heart rate goes up. Lethargy, they're just not responsive. Floppy, maybe. Decreased urine output is huge. Dark, concentrated urine. Sunken eyes. And, of course, weight loss. The combination, the severity, that tells you how bad it is.
And how do we gauge the severity? I know weight loss is a really big clue.
Absolutely. Percentage of body weight loss is like the main way we classify how severe the dehydration is.
Right.
In infants, less than 5% loss. That's generally mild. 6 to 9% is moderate, and if it's 10% or more, that's severe. For older children, the numbers are a bit different. Less than 3% is mild, 6 to 8% moderate, and 9% or more is severe. It just hammers home how vital getting an accurate weight is.
Oh, right.
And tracking those daily weights. Even a small percentage drop in an infant means a lot of fluid deficit because they're so small to begin with.
Weight really is super sensitive. Okay, so we've assessed the child. We suspect dehydration. What diagnostics might get ordered to help confirm things and figure out the type and how bad it is?
Well, it's a mix of that clinical assessment we talked about and lab tests. The physical findings are key. Labs give you that extra detail. BUN and creatinine tell you about kidney function, and they can be elevated in dehydration. Electrolytes, sodium, potassium chloride, absolutely essential for figuring out the type of dehydration and any specific imbalances. Urine-specific gravity measures how concentrated the urine is, usually goes up in dehydration. Serum osmolality gives you the overall concentration of stuff in the blood. Okay. And sometimes you might check arterial blood gases, ABGs, especially if you're worried about acid problems too.
So the labs give us a clearer picture of the internal situation. Now, treatment. Let's talk about how we fix it. Oral rehydration therapy, ORT. That's often step one, right?
That's exactly right. ORT is definitely the preferred first-line treatment for mild, maybe moderate dehydration. If the child can drink and keep it down, it's safe, it works, it's cheap. The key is using those commercially prepared oral rehydration solutions, like Pedialyte or Rehydrolyte.
Right, the special ones.
Yeah, because they have a specific balance of electrolytes and carbs that helps the gut absorb everything optimally. It's really important to tell parents not to use sugary drinks like juice or soda.
Why is that?
Well, they're too concentrated, too high in osmolality. They can actually pull more water into the gut and make diarrhea and dehydration worse.
Okay. Good point.
So the general plan for ORT is small, frequent sips. You're aiming for about 50 to 100 millimolars per kilo over, say, a 4-hour period. Plus, you got to replace ongoing losses from any more vomiting or diarrhea.
Makes sense. Replace what's lost with the right kind of solution. Now, when do we need to escalate to IV fluids?
Okay, IV fluids come in when dehydration is severe, or if the child just can't tolerate anything orally, maybe they're vomiting persistently, or their level of consciousness is down, or they're showing signs of shock.
Right, more serious situations.
Exactly. The first step then is usually an isotonic crystalloid fluid bolus. Think 20 ml per kilo of normal saline, that's 0.9% sodium chloride, or maybe lactated ringers. You give that fast, usually over maybe 5 to 20 minutes, to quickly boost their blood volume and improve circulation.
Get the tank refilled quickly.
Pretty much. Then, once they start stabilizing, you switch to maintenance IV fluids. A common one is D5.45 normal saline, that's dextrose 5% and half normal saline, sometimes with potassium added in, but only after you know they're making urine okay.
Crucial safety check.
Absolutely. And throughout IV therapy, you're watching everything like a hawk. Vitals, urine output, level of consciousness, repeating those electrolytes. Got to prevent complications like fluid overload or ongoing imbalances.
Careful monitoring is definitely the name of the game with IVs. Okay, let's dig into some specific electrolyte issues. Sodium, we said it's key for classifying dehydration.
Yeah.
What are the big nursing points if sodium is too low or too high?
Okay, hyponatremia, sodium below 135. Symptoms can be mild, like weakness or nausea, or really severe, like seizures or coma. The absolute critical nursing point with hyponatremia is correcting it slowly. If you raise the sodium too fast, you risk a really serious neurological complication called central pontine myelinolysis, so slow and steady is key.
Okay, slow correction for low sodium. What about high sodium? Hypernatremia.
Hypernatremia, sodium above 145. Often see thirst, irritability, lethargy, maybe seizures here too. The danger is rapid fluid shifts causing the brain cells to shrink. So again, treatment involves gradual correction, usually bringing the water level back up slowly with hypotonic or maybe isotonic fluids. Careful monitoring to avoid dropping the sodium too fast.
Slow and steady seems to be the rule for sodium. What about potassium? We all know how vital that is for the heart.
Oh, absolutely. Potassium imbalances can really impact cardiac and muscle function. Hypokalemia, potassium below 3.5, that can cause muscle weakness, fatigue, and potentially life-threatening heart rhythm problems, or arrhythmias.
Yeah, scary stuff.
Nursing care involves figuring out why they're losing potassium. Is it vomiting, diarrhea, diuretics like furosemide? Then replacing it, either orally or IV, but IV potassium always needs to be diluted and given slowly, never a rapid push. And of course, monitoring potassium levels and the ECG.
Never push IV potassium. Got it. And high potassium, hyperkalemia.
Hyperkalemia, potassium above 5.5, also very dangerous for the heart. A key ECG finding you look for is peaked T waves. Other signs can be muscle weakness, low heart rate, bradycardia.
Peak T waves, okay.
Immediate management might involve things like giving insulin and glucose that helps shift potassium into the cells. Calcium gluconate can be given to protect the heart muscle from the high potassium's effects. Sometimes sodium bicarbonate or meds like kayexalate that bind potassium. Continuous ECG monitoring is absolutely essential with hyperkalemia.
Definitely critical interventions.
Yeah.
Okay, moving on to calcium. We sometimes hear about things like tetany with low calcium. What should nurses look for?
Right, calcium's crucial for nerves, muscles, clotting, bones. Hypocalcemia, low calcium, can cause that neuromuscular excitability. You might see tetany, those involuntary muscle spasms, especially hands and feet, seizures, laryngospasm, which is dangerous, and those classic signs. Positive Schwasteck's sign, tap the facial nerve, the face twitches and Trousseau's sign, inflate a blood pressure cuff, the wrist and hand spasm.
Fostex and Trousseau's.
Okay. Nursing care is monitoring for these, seizure precautions if needed, and giving calcium supplements, oral or IV. Calcium gluconate is often preferred for 5E because it's less irritating to veins than calcium chloride.
And high calcium, hypercalcemia.
That tends to cause more general symptoms: muscle weakness, fatigue, nausea, vomiting, constipation. Severe cases can cause heart issues too. Management is finding the cause less common in kids, but can happen. Then promoting calcium excretion with hydration and diuretics like furosemide, sometimes meds to stop calcium release from bones.
So every electrolyte has its own critical job, and spotting those signs is so important. Now, the notes briefly mention acid-base imbalances. That can feel a bit, well, abstract sometimes. Can we get a quick rundown of the 4 main types and maybe common causes in kids?
Sure thing. Keeping that acid-base balance right is vital.
Yeah.
The 4 main types are metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis.
Okay.
Metabolic acidosis. You've got a low pH and low bicarbonate, HCO, common causes in kids. Severe diarrhea, you lose bicarb. Diabetic ketoacidosis, DKA, builds up keto acids. Renal failure, can't get rid of acid. The body tries to compensate by breathing faster, like Kussmaul, breathing in DKA, to blow off co-uro, which is an acid.
Okay, metabolic acidosis.
Metabolic alkalosis, high pH, high bicarb, Can happen with lots of vomiting, losing stomach acid.
Right.
Or maybe taking too much Alkalyte, though that's rare in kids. Body compensates by breathing slower to hold on to HuO-Euro. Respiratory acidosis, low
Yes.
pH, high 2 or as level, the PACO. It's because of hypoventilation, not breathing off enough KIOs. Think respiratory distress, bad pneumonia, maybe CNS depression. Kidneys try to compensate by holding on to bicarb.
Makes sense.
And respiratory alkalosis, high pH, low PACO, caused by hyperventilation blowing off too much cures, maybe from anxiety, pain, fever. Kidneys compensate by getting rid of bicarb. Diagnosing these really relies on looking at arterial blood gases, ABGs, which give you the pH, the PACO, and the bicarbonate levels.
That definitely helps clarify the acid-base basics. Now, we've talked a lot about fluid loss, dehydration. What about the flip side? What causes fluid overload in kids, and what does it look like?
Good point. Fluid overload or hypervolemia is when there's just too much fluid hanging around in the blood vessels and tissues. It can happen if IV fluids are given too fast or too much, especially without careful watching, or in conditions where the body holds onto fluid like renal failure, heart failure, or that SIADH we mentioned. Key signs and symptoms you need to watch for. Edema swelling, often puffy face, hands, feet, crackles or rails when you listen to the lungs, bounding pulses, rapid weight gain, maybe increased blood pressure. Sometimes you might see neck vein distension, but that can be harder to spot in babies.
Crackles, edema, weight gain. Got it.
Management is usually restricting fluids, giving diuretics like furosemide to help pee out the extra fluid, watching electrolytes really closely, and of course, treating whatever caused it in the first place.
So it really is all about finding and maintaining that delicate balance. Okay, let's pull this all together. What are the absolute must-dos, the essential nursing management pieces when caring for a child with any fluid or electrolyte issue?
Nursing management is it's everything here. As the notes really stress, accurate daily weights are probably the single most sensitive indicator of fluid balance, period.
Daily weights,
Right.
crucial.
Absolutely. Meticulous intake and output monitoring INO is also paramount. That means tracking everything: oral fluids, IVs, urine, vomit, stool, everything. Nurses have to be constantly assessing for those clinical signs we talked about, both dehydration and fluid overload.
Right, looking for both sides.
Yes. Frequent vital signs, heart rate, blood pressure, respiratory rate, checking level of consciousness, skin turgor, mucous membranes, and carefully reviewing those lab results as they come back. And you have to report any significant changes quickly. Prompt communication with the physician or provider is key for making timely adjustments to treatment.
Definitely.
And maybe one of the most vital roles is family education, teaching parents how to give ORT correctly at home, helping them recognize those early signs and symptoms of imbalance so they know when to seek help, explaining why follow-up is important. That's huge.
Constant vigilance, precise measurement, and empowering families. Seems like those are the cornerstones. That's a really, really fantastic overview of such a critical area in pediatric nursing.
It really is. If nursing students can grasp these principles, they'll be so much better prepared to care for these kids.
So just to quickly recap our deep dive,
Mm-hmm.
we looked at why infants and children are so vulnerable physiologically. We talked about calculating fluid needs, the common causes of imbalances, breaking down the different types of dehydration and how to spot them.
Mm-hmm.
We covered the importance of ORT versus 5E fluids, dug into the specifics of sodium, potassium, and calcium issues, touched on acid base, and looked at fluid overload.
And highlighted that nursing role throughout.
Exactly.
Yeah.
Emphasizing assessment, monitoring, and that crucial family education piece.
Hopefully provides a really solid foundation for students tackling this complex area.
I think it does. And on that note, here's something to maybe think about as you go forward.
Mm-hmm.
Consider how even really subtle changes in a child's behavior, maybe they're just a little more irritable than usual, or their urine output dips just slightly, how those could be the very first clues of a brewing fluid or electrolyte problem.
Good point.
It really highlights the critical thinking and just sharp observation skills needed in pediatric nursing. Maybe think about digging into specific conditions you'll see, like gastroenteritis or bronchiolitis, and how they typically cause these imbalances and what your specific nursing actions will be. Thanks so much for joining us for this deep dive.